and thank you for joining our third webinar of our 12-month series, The 9 Common Dementias. Our program will be recorded and can be found on our Anthem YouTube channel in the coming week. As Nicole mentioned, please keep your microphones off until our Q&A portion, at which time you can either type in your questions in the chat or raise your hand and we will unmute you then. We're delighted to bring back to you a legend in dementia training, Dr. Tam Cummings. Dr. Tam, as she is known in the dementia community, is a practicing gerontologist who has devoted her professional career to educating both professional and family caregivers. In 2009, she founded the Dementia Association with the mission to inspire, educate, and empower dementia caregivers. At Anthem, we utilize her transformative work, including the Itty Bitty Dementia book, in our daily conversations with families of those with dementia. You may have already received your copy of the Itty Bitty Dementia book from your local Anthem community, and if not, it is available on Amazon. Families, professionals, and caregivers, it is an honor to present to you Dr. Tam.
Thank you, Chris. That was so sweet. Thank you very much. I appreciate it. And thank you, Anthem Memory Care. Thank y'all for being devoted to the dementia process and to educating families, to helping others. And because the more that we help each other, the more we learn from each other, the more we understand the disease, the better job we do. So understand that we know you are entrusting us with people that you love and care for. And it is our duty before others and before our God that we will do the best job we can to take care of your loved one. Now tonight, Chris said 3, but this is actually number 4. We're now going to start talking about the 9 most common forms of dementia. And this should really pull some aha moments for you. And you should begin to be able to have some really good questions for your physician and some better explanations for yourself about your loved one's behavior as you begin to recognize these 9 most common forms that affect people with dementia. First, I want you to learn how to do this breathing technique. Now, this is really hard because the minute I tell you to put both feet on the floor and put your hands in your lap and I want you to shut your eyes and breathe, your brain immediately goes, this is really stupid. I sort of already know how to breathe. I don't need anybody to tell me how to breathe. I know how to do that. This is different. This is harder breathing. This is breathing to get your brain to be still. And this is very important because of the time we live in, because your loved one's on a terrible journey, because it's a terminal illness, because you don't have all the answers ready for you the way you would if it was cancer. And so learning how to breathe is the best exercise I can give you for your brain, but it's also a way to help you get prepared for when you go to visit your loved one at Anthem. Before you ever get out of the car, I want you to sit quietly and I want you to inhale to the count of 4. I want you to hold that breath for the count of 2, and I want you to exhale all through your nose to the count of 6. Now, when you actually can do this 10 times, you're beginning to do real breathing meditation, and that is the best exercise we can give you for your brain. But just before you go visit your loved one, to center yourself, do 4 breaths in the complete cycle, and then go in for your visit. And don't stay all day. We don't need you all day. You're messing up our schedule and our programming, and we've got people on a structure because we know that works best for people with brain damage. But when you leave the community, after you've seen your loved one, before you get back on the highway, breathe again. And so right now, Chris, we're going to do a breathing exercise, and I'm going to lead you. And even though I can't see you, Chris can, and he'll call you to see why you're not doing this with me. So I want you to put both feet flat on the floor. You put your hands up in your lap because it helps with circulation. And then you can shut your eyes because we're not watching. And I'm going to count for you, and you're going to do this only through your nose. If you do it through your mouth and your nose, you end up with a dry mouth. So here we go. We're going to repeat this 4 times. Everybody, deep breath in, 2, 3, 4, hold, breathe out, 2, 3, 4, 5, 6. Deep breath in, 2, 3, 4, hold, breathe out, 2, 3, 4, 5, 6. Deep breath in, 2, 3, 4. Hold, hold. Breathe out, 2, 3, 4, 5, 6. Last time, deep breath in, 2, 3, 4. Hold, hold. Breathe out, 2, 3, 4, 5, 6. Now, these next photographs are difficult to look at, but it's part of education for you to understand that what you're witnessing is real. It's just that people with dementia don't look sick until the very end of the disease. All dementias are terminal diseases, and this again is the only disease that is a terminal disease where when the family leaves the doctor, they have no idea. They've just been told a terminal diagnosis, and if you knew that, you could make better plans with your loved one. And so we need to do a better job of telling people that. Everything you're watching your loved one do, if you tell me the behavior, I'll tell you the part of the brain that's damaged, because each part of the brain, each lobe of the brain only does certain things. And once those behaviors change in a person, it indicates damage is now in that brain. So words that I want you to take out of your vocabulary as a family member, as a professional caregiver, as a caregiver, as anybody related to somebody with dementia, I want you to remove the words faking, showing off, pretending like, acting like, denying that they have dementia. They're not doing any of those things. Those things take an entire full-pound brain. What your loved one is doing is they're simply showing you what the effects of brain damage are. And that's what you're witnessing. It's just you always have to remember, my loved one won't look physically sick here on the outside until very, very late in the disease. So they're not pretending, they're not showing off, they're not acting like, they're not doing these things to annoy you. It's just brain damage. Now, there are 9 common dementias. We've so far identified about 128 in total, and in the Itty Bitty Dementia book, because, Chris, I occasionally run into people who go, well, what are all the dementias? They're listed in there. There are about 70 dementias that we refer to as children's Alzheimer's. They are syndromes that attack children in the brain, and they are terminal. We don't usually see them because they're very rare, and the parent cares for the child. Of the remaining dementias, 9 of them are about 98% of all the dementias, but there's one dementia, Chris, that I don't keep on this list, but I always want to ask and warn families about, and that's toxic dementia. So toxic dementia can happen because my father was a farmer and a rancher and a builder. He was exposed to chemicals. My brother-in-law was a painter. He was exposed to chemicals, to toxins. I might have somebody who served in Vietnam or served in Desert Storm and was exposed to Agent Orange or to other toxins. We know that we see higher levels of, for example, Parkinson's and Lewy body in places where there is oil or gas or some other chemical that is mined or harvested, or that there's a plant there. So we see higher levels of those in Galveston, in certain areas around Pittsburgh. We have higher levels that are somehow connected to this toxicity that a person might be surrounded with. So here's the 9 most common forms. But in the back of my mind, I'm always going to ask the person, is there any chance they were ever exposed to something toxic? Now, these are the 9 most common forms. And you remember, the way this works is the way any medical diagnosis works. I take the person's age, their physical characteristics, their behaviors, the things that are driving you mad are actually clues to us as to the type of dementia your loved one has, or to the stage of dementia, how progressed the disease is. And then you take your person's age, their sex, their clinical features, you remove what it can't be. So remember, my mother is 83 years old. She never played football, so I can take off number 9, chronic traumatic encephalopathy. My family does not have Huntington's disease. This is a dementia that is inherited. It is passed from the parent to the child, and the child is either a carrier of Huntington's or they have Huntington's. My family doesn't have that. Wernicke-Korsakoff is alcohol dementia. My mother's never had a drink in her life. I feel good to mark that one off. She doesn't have Parkinson's disease, so she can't have Parkinson's disease dementia. She's much too old for the frontal temporal dementias. These are dementias of people in their 40s or 50s, maybe into their 60s. She doesn't have Lewy body dementia because of those 4 common hallucinations. She doesn't see children. She doesn't see bugs, spiders, rats, or snakes, bad people coming to get her. She doesn't see everybody having sex. So I can feel good to rule out Lewy body dementia. But my mother's now had 2 stents put in her heart and is scheduled for 2 more due to blockage. My mother has high blood pressure, cellulitis, hyperlipidemia, high cholesterol. She's got documented stroke activity. She has cellulitis, obesity. Her father was a smoker, and I mean real cigarettes, cigarettes with no filters on them. My father was a smoker, real cigarettes, no filter on them. And we know there's an effect of secondary smoke to causing both cancers and dementias, but all of those things make me want to ask the doctor about a vascular dementia in my mother. And then she's in the age group of the 80s where the category numbers are now 1 in 6 will develop a form of Alzheimer's. And if there's another dementia in place, Alzheimer's is going to join it. So for my mother, I go back to ask about number 3, vascular dementia, number 2, Alzheimer's dementia, and a combination of those is number 1. But you may also have someone more like my father. My father's 60. My father is 88 years old. And my father is a farmer, a rancher, and a builder. So I want to make a little check next to toxic, even though I don't think anything happened, but I still want to make a check next to toxic. Now, my father was a quarterback on a 6-man football team that won the Texas state title. Now, 6-man football means the school is so small that there's not a lot of tackling. It's a lot of running because the boys play both offense and defense. But I still want to let the doctor know this could have had some impact. My family doesn't have Huntington's. My mother didn't drink, but my father did. And even though my father's been sober for 30 years, and I'm not talking about you watched the Super Bowl on Sunday and you had a beer. I'm talking about a case of beer and a bottle of whiskey a day. Serious drinking that went on for 30 years. And drinking causes alcohol dementia. And even though my father's been sober for another 3 decades, I still want to check off that there is that history of alcohol abuse in his brain. He doesn't have Parkinson's disease, so he can't have Parkinson's disease dementia. He's much too old for the frontal temporal dementias. He doesn't have those Lewy body hallucinations, but for every cold beer in one hand was an unlit cigarette, an unfiltered cigarette in the other hand. His mother smoked unfiltered cigarettes. I'm pretty sure my father was smoking by the time he was 6 years old. And even though he's this big around, he weighs 130 pounds, he still has high cholesterol. So I'm going to make a check next to vascular dementia. And then at 88, he's now this much closer to the 90s. And in the 90s, the odds now become 1 in 2 of Alzheimer's. And you can see from my father's history, there's several questionable things there that would make us think we might ought to ask about Alzheimer's as well. So for my father, I would actually use this chart and go back to ask about toxic dementia, number 9 CTE, number 7 Wernicke-Korsakoff alcohol dementia, number 3 vascular dementia, number 2 Alzheimer's dementia. Those together would be a mixed dementia. And we know now that that's much more common than we thought it was before. So the first of those dementias is mixed dementias. Now, in the beginning, when we came up with these scales, mixed dementia meant that we were talking about a mixture of Alzheimer's dementia and some form of vascular dementia. But then as research went on, it was realized that if you had any dementia and lived long enough, Alzheimer's would join it. And then in time, it was recognized you could have any dementia and also develop a vascular dementia because of your cardiovascular system. Then it began to be realized that this type of dementia could also associate with this type of dementia. For example, in Parkinson's is now part of Lewy bodies. If you have Parkinson's, you're going to get Lewy bodies and then Alzheimer's, but you could also have Parkinson's and develop a rare form of FTD, frontal temporal dementia. So we begin to realize that dementias could be joined with any other dementia. In fact, some dementias only occur if another dementia is already in place. Those are called secondary dementias. And so if the doctor uses the term mixed dementia, you want to know which group or set of dementias is the doctor referring to, because again, that gives you information as the family caregiver. It gives you information for your medical history, your children and grandchildren's medical history. It gives you an idea of what staging tool to use. It gives you an idea of the trajectory of the disease. What are the behaviors that you're going to see occur? Now, this is a brain with mixed dementia, and you see the open area there, what's called the butterfly, the ventricle. On you and I, that is much, much smaller. That's probably a quarter of that size. And where that has opened up now, there's no brain tissue there. The brain should also go all the way to the end of the cranium, and instead this brain has shriveled, it is atrophied, it's got holes in it. And then if you can see, there are two arrows pointing to white areas. But if you could see the original scan, there's a lot more than two white areas. There are actually 50 plus TIAs, transient ischemic attacks, little strokes, tiny strokes, baby strokes, mini strokes, pinpoint strokes, that then accompanied and became these bigger strokes. And the result of this brain is this person has a vascular multi-infarct, multiple stroke dementia, and then they developed regular onset Alzheimer's, and that would be called mixed dementia. So Chris, does that make sense to you?
Yes, that makes perfect sense.
Okay, so they began with stroke activity, and that stroke activity is so subtle, it happened for maybe decades before anyone noticed it. It was the cumulative effect that began to make somebody suspect something was wrong. And then because the brain was damaged, Alzheimer's joined as well. Now, when someone says to me, my loved one has dementia, I always say, which dementia? And when they say my loved one has Alzheimer's dementia, I say, which Alzheimer's? So it's no different than cancer. If you said cancer, I'd say which cancer. If you said lung cancer, I'd say which lung cancer. And if you said small cell oat carcinoma, I would know what you're talking about, because you've now given me the actual name of the disease that your loved one has. So Alzheimer's is currently broken into 4 domains. The first one is early onset, but it may also be called younger onset Alzheimer's. And you have to ask yourself, if medical professionals can't make their mind up, how are we ever supposed to understand this? And I agree with you. What early onset or younger onset Alzheimer's means is it means the age of the person. And Chris, where this most commonly gets confused by families is the doctor said that their loved one was in the early stage of dementia, and by the time they got home, that had become early onset Alzheimer's. Early stage is talking about how progressed a disease process is. Early onset or younger onset is telling me this is a younger person, typically somebody below the age of 65 to 60. Now, your training is, because this is actually a very small number, and because only about 5% of this group have familial early onset Alzheimer's, your first training is to not think early onset Alzheimer's. Your first training is to rule out frontal temporal dementias, because those dementias also occur in this same timeline, but they're a larger group of dementias. So you first look to that group. But if that group doesn't work, then the doctor's fallback is going to be to go to early onset or younger onset Alzheimer's. Now, about 5% of these dementias are inherited from the parent, and of those families, they've been able to trace that this group all evolved from a valley region of Germany centuries ago. And this is some sort of genetic link. Otherwise, a person developing early or younger onset Alzheimer's is a sporadic event, and we don't understand why it happened. Everybody in your family is aging normally, and suddenly your 35-year-old sister has Alzheimer's. And so this is very frightening, very scary, and this is very, very aggressive as a dementia because the person is so young. But again, it's very, very rare. And just to try to make this clearer, you cannot be 88 years old and have early onset Alzheimer's. You can't. You may be 88 years old and have early stage of Alzheimer's, but not early onset. That's actually the name of a disease. The second domain of Alzheimer's is Down syndrome Alzheimer's. And this means that people with Down syndrome, we do anticipate, will develop this form of Alzheimer's. This is a very aggressive form. And this is one of the few forms of dementia that changes a person's personality. So when you think about how a person with Downs, their gentleness, their openness, their kindness, there's just not a mean cell in their body. This person is now very agitated physically and verbally, and a much, much different presentation for their loved ones. This person, in other dementias, the person doesn't know how to put on or do their ADLs. In Down syndrome Alzheimer's, the person will suddenly refuse to do their ADLs. So I may say, Mark, it's time for you to get up and get out of bed. And Mark says, no. And that's a completely different presentation than what is normal for Mark. This, again, is a very, very aggressive form of dementia because we are only just now, Chris, beginning to see our first 80-year-old people with Down syndrome. And that has never happened before. And it's a very small group. Behind them, we have a group in their 70s. Behind them, we have a larger group in their 60s. We have a little bit larger group in their 50s. But this does strike that group, and it is very, very aggressive. The dementia that we march for, the dementia that you talk about, the dementia that you read about or see on TV is regular onset Alzheimer's. And when they talk about regular onset Alzheimer's, we're talking about people who developed this cognitive impairment to where their family could see it beginning in their 60s and 70s. And because of the progression of the disease, by the time it's diagnosed, it's typically already in stage 5. That's why you see information that says a person dies within 5 years of diagnosis of Alzheimer's. It's because they're simply not diagnosed in time. You tried to get them to the doctor, you saw the difference, but because the human brain isn't able to tell that it's not functioning normally or that it's doing something irregular, every time you tried to point out what was wrong with your loved one, all you did was make them angry with you, because it's very insulting to humans to have someone question our cognition. Now, regular onset Alzheimer's is considered the big group of Alzheimer's because of the large number of population of people we have in their 60s and 70s. This also includes some very rare and very aggressive forms of regular onset Alzheimer's. Atypical frontal variant is one form, and this is typically misdiagnosed as behavioral variant frontal temporal dementia. The difference is behavioral variant frontal temporal dementia person is gaining weight rapidly. Atypical frontal variant people are losing weight rapidly. Posterior cortical atrophy, you may have been told by the doctor, cortical atrophy. This person's skin feels like it's prickling. They have terrible headaches. They're slowly going blind because the damage is in the rear of the brain where the occipital lobe is. And then there's a very rare form called logopenic variant, but there's also a form of frontal temporal dementia called logopenic variant. So in both of these dementias, there's going to be a tremendous inability to correctly use language. And it's truly, the diagnosis, Chris, is going to be based on the skill set level of the neurologist and the geriatrician that are doing the testing on this person. Late onset Alzheimer's is people in their 80s or 90s. And this is a slower moving, slower progressing dementia, but still the person's in their 80s or 90s. By the time the person reaches their 90s, the odds are now 1 in 2 that the person will develop a form of late onset Alzheimer's. So, Chris, do you want the good news or the bad news? What you want? Good news or bad news? How are you feeling? You're in your 90s, 1 or 2. What do you want? Good news or bad news?
Give me the good news.
You're probably not going to live to be 90. You want the bad news?
Yes.
You're probably not going to live to be 90. So it's sort of a win-win, lose-lose. I mean, we're seeing for the first time ever a large population of people in their 10th decade of life to study. And what we know is what we know about memory care. For any of us to age well, we have to have socialization, activities, and kind people around us. And that is one of the critical features of living into any old age. It's also the critical feature of good care in dementia. And it's one of the things that you guys do. In late onset Alzheimer's, we have found that there are two variations. And one of them, Chris, I write, this lady has type A late onset Alzheimer's. She is pleasantly demented, which is a terrible phrase, but we use it medically. In another report, I might write, this person has late onset Alzheimer's type B, run for your life. Because type A is a very social person with dementia, type B is a very agitated person with dementia. So we do recognize now that there are two distinctive types. And then realize that any one of these domains can also have variations that drive the person's behavior. Usually, and as you look at all these things, it says delusions, which is a belief that's not real. The most common belief that's not real in dementia is that you, Chris, were the last one here. I can't find my purse. You must have stolen my purse. I'm accusing you of taking things or stealing things because I don't remember them. The hallucination in Alzheimer's, it could be a true hallucination where I'm seeing, hearing, or smelling something that's not real. But families and professional caregivers have to be able to differentiate, is the person with Alzheimer's having a true hallucination or having a perception issue? If it's a hallucination, I need to see the doctor. If it's a perception issue, I don't need to see the doctor. It's part of the disease. And here is the difference. A hallucination, I see, hear, or smell something that's not real, and it usually goes on for several minutes or even several hours. A perception issue is I'm not seeing things clearly, and because of brain damage, I think something else is happening there. So I'm sitting on my couch and there's my window, and a car goes by the window and it makes a shadow move across my curtain, across my window, across my couch. And my brain goes, oh, curtain, car, couch, shadow, big deal. And it throws it out and I never remember it. But to a person with Alzheimer's, they might begin to tell you there's somebody at that window trying to get in the house, because their brain can't make sense anymore of what that shifting movement shadow was. Does that make sense? So you have to figure out, is it a hallucination or is it a perception issue? They believe they're being persecuted. I believe, Chris, in my delusion, that you're trying to steal from me. You're out to get me. You're trying to do something bad to me. And it's because of brain damage. And then agitation, anxious presentation, or aggressive forms of behavior most commonly have their root in untreated chronic pain. So Chris, just to share a little bit with you right now, I have arthritis, but I also have in this moment the L5 vertebra of my spine twisted. And because of that, some set of muscles, my chiropractor called the para something, 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 something muscle, it has pinched my sciatic nerve across my left pelvic bone in two places. So if I let myself just feel the pain right now, I would actually begin to cry. But all our life, you and I have been taught to push pain down, push pain down, push pain down. I can't get my job done if I sit and feel what's happening in my hip. I can't retain my train of thought for the presentation if I think about my hip. You as a male have been taught even stronger messages of don't let somebody see you hurt. So if we don't treat these people, if you, the family, don't tell us about a broken bone, about arthritis, bursitis, tendonitis, a rotator cuff, a replaced hip, a replaced knee, if you don't help us get the doctor on board, you're going to see agitation, anxious, and aggressive forms when we could take care of that with medication. So remember, we're counting on you to help us in some of these behaviors. Now, this gives you a greater breakdown of the differences between PCA and frontal variant. They're much more common than logopenic variant is. The brain is damaged again. In posterior cortical, it's due, oddly enough, to a zinc deficiency. Now, Chris, that does not mean you all need to go run out and start eating zinc. This is a dementia that happens to people in their 40s and 50s, and death occurs by the early 60s. Nausea, dizziness, the skin feels terrible, terrible headaches. Frontal variant, irritable, paranoid. That could have been me earlier today. But this one is going to typically be misdiagnosed as frontal variant, behavioral variant FTD, or even as a vascular dementia. So you're going to have to give the doctor a lot more information about things like neglect of personal care. compulsive behavior, snatchy, grabby behavior, because that's not part of vascular dementia. That's part of frontal lobe damage. Preservication is staying stuck on one thing forever and ever and ever, Chris, till I just want to pull all my hair out. Hyperoral is putting anything I find in my mouth, including things that I shouldn't be eating. So you're seeing a lot of damage in the frontal lobe. And if the doctor doesn't know this, your person's going to get the wrong medication. They're not going to be treated in the way that they should be treated. Now, this is a normal brain and a dementia with Alzheimer's brain. And that's actually how dementia with Alzheimer's is written. It's DAT, dementia of the Alzheimer's type. And the difference in these two slides is you see how much smaller the butterfly is, the correct size. But then in the dementia brain, what you see is every place where you see the dark areas, Chris, there's no brain tissue there. That's cerebral spinal fluid, and that person is in stage 5 of the disease. They still look like nothing's wrong with them. They still got family members saying they're okay to drive. They know to turn around and come back. And the reality is, no, they don't. They have serious brain damage. It's just you can't see it. Now, the vascular dementias, Chris, there's about 4 dozen kinds of these. The most common one is multi-infarct, meaning multiple stroke. These are the most common types of strokes that you and I here talked about. Hemorrhagic stroke, we don't really deal with in dementia because people with a hemorrhagic stroke, the blood vessel has actually ruptured in the brain, and they typically don't survive that stroke. Ischemic stroke is the stroke you think about where I've had a stroke on the left side of my brain and I can't move the right side of my body. Everything seems frozen and isn't working right. If it's happened on the right side of my brain, then the left side of my body won't work. Then TIAs, transient ischemic attacks. Most of these strokes occur in the middle of the night. And at this point, the reason they're called pinpoint strokes, baby strokes, little strokes, tiny strokes, is because they're actually microscopic strokes. They're occurring in blood vessels that are smaller than a strand of hair. Most of them occur in the middle of the night. If you saw one of them, it would look like the person might have a seizure for a few seconds or a few minutes. Those are what strokes look like. In dementia, those types of strokes are called seizures, but it's actually a stroke activity. And so those are your main strokes that we work with. And Chris, it's not the one TIA because it's microscopic. It's the 50 or 60 or 70 TIAs that cause the damage. It's the cumulative effect over years or decades of this disease slowly beginning to happen to this person. Binswanger and CADASIL, these are forms of vascular dementia that tend to strike primarily males and usually in their early 40s. Diagnosis and death occur within just a couple of years. And as you're looking at your loved one's test results, if you see things that say white matter, gray matter, white matter, hyperintensitives, white matter, gray matter, you're talking about an MRI that is telling you vascular dementia. And then also for the first time since it happened 3 years ago, Chris, the federal government changed the name of dementia to major neurocognitive disorder. So it's no longer dementia, it's major neurocognitive disorder. Last week, for the first time, I saw major neurocognitive disorder written on the summary page of an MRI. So it is beginning to be out there. Now, white matter is different than gray matter. Gray matter is what you and I think of as the brain because it's gray. White matter is where the neurons in the brain begin to be lengthened and tied into the nerves that are going to allow your entire body to work. Everything from you can speak, to you can hear, to you can chew and swallow food, to you can stand and walk, to you can hold yourself erect. All of those are happening because of the connectivity in the white matter. And it's called white matter because it's long and it's sheathed in myelin, and myelin is white. So gray matter, white matter. When you have disease in the white matter, that's a vascular dementia occurring, and this person's going to have more falls, more problems with connectivity, more problems with their body not working correctly because of where the damage is occurring. In each of these brains, there is damage from stroke indicated by the white areas. Now, Chris, person A has had a massive stroke in their left temporal lobe, and as you and I know, the left temporal lobe is formal language, how you and I talk to each other. The right temporal lobe is singing and cussing. They've had a massive stroke in their left temporal lobe. I'm pretty sure that to the doctors, the nurses, and to everyone around them, they're singing and cursing. And if we don't explain this to families, families think their person is doing this on purpose. And what families need to understand is this is an indicator of brain damage. And for reasons we don't understand, that left side does usually die first. Now, Lewy bodies is named for Dr. Lewy. It is a protein that should live in the fluid of the brain, and for some reason it manages to get into the brain cell. When that happens, if the Lewy body lays in front of the dendrites like it is in that graphic, then the person appears not to be thinking clearly. But if it slides just a little bit to one side, the person's brain works fine, and that's called fluctuating cognition. And on the day you took your loved one to the doctor, the chances are really, really good. You got them up, you got them dressed, you got them shaved, you got their makeup on, you got breakfast in them, you put them in a car, you drove them through traffic, you got someplace, they got to a doctor's office, the doctor is dressed in the doctor's uniform they've had all their life. You and I have been taught to always be polite to doctors. Doctors walk in, they cue the social skills, which you and I learned beginning the day we were born. And it starts with, hi, how are you? And your loved one immediately went, well, I'm fine, doc, how are you? And you wanted to kick the snot out of them. And what you were actually witnessing was fluctuating cognition. And you got a lot of brain cells going this morning. You got a lot of stuff happening with your loved one. Main features of Lewy body is that this person sees 4 hallucinations, and they may see one of these, they may see all of these. And what's so frightening for me, what's so frightening for them, is these hallucinations are going on for hours, not for minutes. They see children, bugs, spiders, rats, and snakes crawling on them and biting them, bad guys coming to get them. They see their spouse or their caregiver having sex, even though it's right through that door, right through that wall, they can see it. Even though it's downtown in front of the grocery store, they can see it. And what's so terrible, Chris, is this is a clear indicator of Lewy bodies, but because it involves my parent talking about sex, I'm embarrassed to tell the doctor. And I actually need to be telling this to the doctor because this is a clear sign of a great possibility of Lewy bodies. They have REM sleep behavior disorder. And what that is it's the inability of the person to sleep through the night without kicking and punching. If they dream they're kicking and punching and fighting and running, they're kicking and punching and fighting and running. And it's to the point, Chris, where they can hit and injure their loved one, or they can kick them and throw them out of bed. They have systemized delusions that can be sexual in nature. And when I say that, the delusion comes out like this. And remember, a delusion is a belief that's not real. The first time I heard it, the man told me that he was ashamed to admit it, but his wife was having sex with the drug cartel. And every day the drug cartel was in the news. And what he knew was that tomorrow the DEA was going to raid the drug cartel, and he didn't want his wife on camera, on the television, naked having sex with the drug cartel. And of course, what he didn't realize is he was having a hallucination, and it was a sexual hallucination, which meant it was very, very difficult for his wife, what she had gone through. But when you listen to it, you think, now that's absolutely crazy, until you realize he'd been watching the news, and every day on the news was the drug cartel, and he was simply having the sexual hallucination that goes with it. They have sudden crashing depression. This is our second highest suicide group because as part of Lewy bodies, their brain stops making serotonin. They have crashing depression. They've got to be on antidepressants. They have fluctuating cognition, makes you want to just pull their heads off, trouble with executive function much sooner than other people and than other dementias. And in this dementia, the other dementias are accusing Chris of stealing from them in stage 5. Lewy body people are beginning to accuse their spouse, their children, and their caregivers of stealing from them as early as stage 3 of the disease. That's very, very early in the disease process. They have trouble with visual spatial function. They have trouble with executive function, the ability to plan and carry out. They don't necessarily get fired from the job. They come home and tell you they quit their job today. And they signed a piece of paper that gave away their retirement. They did something that's completely, completely out of order for them. They have a lot of falls, and their falls are called planking because they suddenly stiffen like a plank, Chris, and they fall forward, hitting the front of their head. They fall backwards, hitting the crown of their head. Their fainting is not related to blood pressure or to high blood pressure or to some sudden change in vascular. It's related to the damage in their brain. And like people with Parkinson's, they also have constipation issues that are not related to diet or exercise or fluid intake. It's part of their brain damage. They're extremely sensitive to medications. And if the hallucination, Chris, is the sexual one, the spouse is at a real risk of sexual abuse. I've actually seen a gentleman who had Lewy bodies dementia and had the sexual spouse hallucination. And he decided if his wife could have sex with everybody in town, she could have sex with him. And he got a calendar and wrote down the days and times she would have sex with him. And as you can imagine, that put a tremendous amount of stress on her. Now, Lewy body brains look different. Lewy body starts in the basal ganglia, backwards area of the brain, and there are multiple mutations of Lewy bodies. This was not understood until recently. Well, we don't understand it. We just know it's there. So for Lewy bodies, Chris, what we see more and more is that the spouse has been trying for at least 5 to 10 years to get the primary care physician to see that something is wrong with their loved one. And they've been told everything from there's no problem with him, but you're crazy. They've been told the only person here that needs counseling is you. They've been told that they're nuts. And in the end, they get proven correctly. So go to lbda.org. That is the Lewy Body Dementia. Actually, I've got that backwards. Lewy Body Dementia Association.org. And then also go to nih.gov. That is our repository of information and research. Look up Lewy Bodies Handbook, and you can order a free one. It's one of the best 40-page books you'll find on Lewy bodies, and you can get the PDF automatically sent there to you right away. And that's one of the best books you can get on Lewy body because it is a much different dementia. The frontal temporal dementias, Chris, these are the dementias that we're supposed to think of when we have somebody in their early 60s, even their mid 60s, especially in their 20s, 30s, 40s, or 50s. This is the dementia that we're looking at. The first two are referred to as the behavioral dementias, behavioral variant, FTD, and Pick's dementia. The FTDs are actually based on the work of Dr. Pick. These two have a lot of behavioral issues that come with them, and it's due to incredible amounts of damage that occur in their frontal lobe areas here. The next group are the communication disorders, primary progressive aphasia, semantic dementia, and logopenic variant dementia. And remember, there's also a logopenic variant Alzheimer's. You got to make sure it's not that one. But in these dementias, families simply look at the clinical features and realize that this is how their person began to change in their use of language. And most times it's the families who make this diagnosis. In fact, on all the FTDs, it's usually the families, because most of the time, Chris, if I meet a family whose loved one has FTD, they have only been told your loved one has FTD. And when I say which form of FTD, they have no idea what I'm talking about. And the type of FTD is like all of the dementias. You need to know which one it is because the differences in the behaviors are quite extraordinary. Now, prosupernuclear palsy, cortical basal ganglionic, FTD with motor neuron, and ALS with dementia, those are all considered the motor diseases of the frontal temporal dementias. And of these, cortical basal ganglionic and FTD with motor neuron disease will join other FTDs once they're in place. FTD with motor neuron disease and cortical basal ganglionic will also join Parkinson's or Lewy body. And it's because all of these dementias start in the basal ganglionic area of the brain. So they're in areas that are very close to each other. And it's believed that's probably the connection between them. And Chris, just to make it worse, every single one of them is considered a first cousin of dementias of the Alzheimer's type. So we expect somebody with frontal temporal dementia to also develop Alzheimer's as part of the disease process. Now, this is the brain of a person with behavioral variant FTD. And when you see this brain, Chris, when you see different slides of this same brain, it is absolutely horrifying because there is no brain tissue left here. And because there's no brain tissue here, this person has no feelings for their family, for their children, for their spouse. They have no feelings about anything. And it's not because they're a bad person. everything that person does, it's all directly related to where the disease is in the brain and what's happening to them. One of the quick ways is people with Alzheimer's don't know who, what, where, when, why, or how, but they have all of the emotions. They're glad to see you, Chris. They're mad at you, Chris. They don't like you, Chris. They love you, Chris. People with FTD, it's a much different presentation. They don't have the emotions, but they still know who, what, where, when, why, and how. And it's because their hippocampus, the piece of the brain that makes memory, the piece of the brain that looks like a little seahorse, that piece of the brain doesn't die until much, much later in the disease. And so people with FTD have an understanding of what's happening to them. They just don't care. And it's because, not that they're bad people, it's because the piece of the brain that has emotion in it doesn't exist anymore. Now, Parkinson's disease dementia has been since about 2 years ago, Parkinson's disease dementia was pulled under the Lewy body dementia umbrella. It is now considered a variant of Lewy body. And what we know about Parkinson's disease dementia is if the person began movement disorder first and then cognition, it's Parkinson's. If they had cognitive issues followed by movement issues, it's Lewy body. But what we know is that the hallucinations are similar, although some of the behaviors and delusions happening in Parkinson's are actually due to the medication. But we know if the person develops Parkinson's disease that we're watching for the onset of Lewy body dementia and then Alzheimer's dementia. If they have Lewy bodies, then we're watching for the onset of Parkinson's dementia plus Alzheimer's dementia. So we know that these three dementias go together. Their delusions are more paranoid than based on necessarily what's been going on the news. They're very soft spoken, not because they're trying to drive you crazy, but because of the disease process. They're not able to push air through their vocal cords to get volume. They have the REM sleep behavior disorder. They have a lot of trouble with visual interpretation. Chris, I met a woman about a couple of months ago, and she was so mad at her 96-year-old husband. She's 95. She's so mad at him because he has Parkinson's disease dementia and he refuses to hand her the clicker. Now, you should know that the black remote control is sitting on a black end table, but you should also understand that people with Parkinson's, people with Lewy body, people with any dementia do not see things the way you and I do. And even if it's right in front of them, especially Parkinson's and Lewy body, even if the object's right in front of them, they can't see it. That's the clicker. That's food, that's something to drink, that's whatever's in front of them. They're not able to see it. They're not pretending, they're not acting like. They tremor, they have stiffness. It's called ratcheting, where they can't move their arms and legs and their body correctly. They have a mask face, meaning that their face has no emotional movement on it. It's as though they're wearing a mask. They fall very much like Parkinson's, flat down, forwards or backwards. And they tend to have more changes in mood and behavior as the disease progresses than what we see in other forms of dementia. So remember, the later in life you develop Parkinson's, the more rapidly it becomes Parkinson's disease dementia. So the later in life a person develops Parkinson's disease, the more quickly it becomes Parkinson's disease dementia. Wernicke-Korsakoff is multiple things. The person could have drank long enough to develop Wernicke. They could have drank long enough to develop Korsakoff, or they could have both of them together. Now, in care, this is a challenging person for us to do care for. You've got to understand the damage they did to their brain. It's like someone poured acid in their brain. They're very impulsive, they're very snatchy, they're very grabby. About 1 out of 4 smear their feces on walls, on everything around them because they're mad at their caregivers. You may have dealt with this at home. You can look at them. The eyes don't look right. The eyes don't move right. They have difficulty with balance. Some of them have abused alcohol so long that even when they're sober, they still appear to be drunk. They can be easily agitated. It's not at all unusual that they will not come out and do activities with us, no matter what we do, unless we say happy hour. And Chris, when we say happy hour, all of the people who have an alcohol dementia, a Wernicke-Korsakoff, then they'll come out because we're doing what they needed. You need to be aware that depression is going to be part of this dementia that needs to be looked at, as well as anxiety, because we now know people that drank to the excess of becoming an alcoholic or developing Wernicke-Korsakoff, that a lot of times they were trying to self-medicate for anxiety and depression. It's just they ended up developing a brain disease as a result of it. So be aware, they are more challenging for us to take care of. They're more challenging for you. And because of what alcoholism does to a family, this may have broken your family. You may find yourself taking care of somebody who abused you. And so if you had that, be sure to reach out to your Anthem family and talk to them. They're prepared to help you because they understand the grief, the guilt that all of these dementias bring, but especially when they've come from a dementia that may have caused terrible things to happen in your family. So we understand what you're going through. The next one is horrible. This is our highest, most successful suicide rate. And it's that way, Chris, because you know you inherited it. You either have it as a child, which is juvenile Huntington's, and you die as a child. You are allowed to be tested at the age of 18, the age of majority. At that time, you know you either have it or you're a carrier. If you're a carrier, it means that if you have children, you're going to pass it to them either as a dementia or as a carrier. And frequently when we see these families, these are very hard for us as well as you, because I see these families, the spouse may have outlived every family member they had because everybody got this disease and died. The person knows they have it. They know that mom began to show symptoms at 35 and died at 42. That's their trajectory. So they commit suicide and are successful with it. Huntington's chorea. Chorea means jerking. Now, everybody understands a tremor. We think of a Parkinson's tremor or a Parkinsonian type tremor. But in Huntington's, chorea means that the limbs are actually jerking. And to give you an idea of how much jerking, the average calorie count we're shooting for in dementia is 2,500 calories a day. We get nowhere close, but we try. The average calorie count for a professional football player, 3,500 calories a day. The calorie count for a person with Huntington's chorea, 7,000 calories a day. And there is obviously no way in the world we can get those kind of calories into a person. So again, a very, very aggressive disease, usually requires antipsychotic medications, very, very, very rare, but we see it and we care for it in our communities. And you have to understand this takes a toll on you. It also takes a toll on our community and our caregivers there because of the love that they have for the people they do care for. When your loved one has an FTD, when your loved one has a Huntington's, they're going to age at a rate you would not believe. And the person that you brought us to do care for that was in their 40s or 50s, who's near the end of life, is going to die in a year or 2 years looking like they've aged 40 years. And it takes a toll on all of us, but we're there to help you and we're there to help each other. But this is truly one of the most horrible dementias. CTE, this is chronic traumatic encephalopathy. This is not boxer's dementia. That's called pugilist dementia. This is dementia caused by a person's brain being constantly pummeled in the game of football. It is believed from research that if a young man started playing pee-wee tackle football and played on the line, that by the time that young man graduates high school, he has been in the equivalent of 3,500 head-on collisions of 35 to 45 miles an hour. Research shows that it's not just the front of the brain and the back of the brain that are hit in the blows, but side blows to the player also cause the brain to twist at the brain stem. If you think high school and junior high boys are playing with the helmets and the protection that professional players are playing with, that's not being very realistic. And I can tell you, Chris, that every single time on the news I see a 15-year-old football player, 18-year-old football player, 25-year-old football player, 30-year-old football player, 40-year-old football player do something absolutely ridiculous, stupid, or dangerous, I don't think they're a bad person. I immediately wonder how advanced their CTE is. The youngest person in our country to die was a 17-year-old young man who had stage 4 chronic traumatic encephalopathy. This is the only dementia graded on 4 stages, so it's actually graded on a separate tool. And Chris, you can see we got a little bit of a gap there. We've got young onset, ages 18 to 35, late onset, ages 60. There's got to have something for that group 36 to 59. So there's more information coming. It's just this isn't a big group to research. Out of the 1,700 NFL players who have been autopsied, all but one of them had advanced CTE. So it is a very dangerous game. There have been 4 identified domains, the movement disorder one, cognition, language, mood, and there's even a combination of all of the above. So the person can have any one of these things happening. Obviously, these men fall, and they're very difficult for us to take care of because these are giant people. I don't know if y'all have ever seen a professional football player or a college player. These are big men. So they're a challenge for us. And they're a challenge for the family. And it is truly, truly, it's a very aggressive disease once it starts. And the younger the person is, the more aggressive the dementia is. Chris, usually at this point, I've depressed everyone terribly, and we all need to breathe. So we're going to do 2 counts of breath. So feet flat on the floor, hands up in your lap. You can shut your eyes if you want to. I'm going to count your breathing. Everybody breathe in, 2, 3, 4, hold, hold, breathe out, 2, 3, 4, 5, 6. Everybody deep breath in, 2, 3, 4, hold, hold, breathe out, 2, 3, 4, 5, 6. Chris, if you do this, and you can do this for just a few minutes, when you reach meditation, your breathing rate will drop from 13 breaths per minute to about 8 per minute. And 8 breaths per minute is referred to as the prayer state or the meditative state. And this is where the brain is able to repair itself. It's able to increase connectivity. It's able to both rest and exercise. This is the best thing I can give you. Now, this does not work on people with dementia because their brains are dying due to different types of diseases that are killing the brain cells. But for you and I, Chris, this is the very best exercise I can give you. So, understanding dementias. Does that make better sense, Chris?
That makes better sense. Thank you.
Do you see how to go back through with your own loved one and be able to go back to the doctor with better questions just by understanding those 9 most common dementias and always keeping toxic dementia there in the background?
I do. I do.
Wonderful. Okay, does anybody have any questions?
So we do
That's
have,
how good I was, Nicole. Nobody had any questions. So there
yeah.
we go.
No,
Leave
we
it to
did
me,
have
y'all.
Elizabeth has a question about Alzheimer's. Elizabeth, do you want to come off mute?
Thank you, Dr. Tam. This is the 3rd one I think I've been to, and these are fantastic. My mom has been in an Anthem memory care since November 20th, and I have a quick question. I was filling out a long-term care insurance application today, and one of the questions was, do you have a parent or a sibling diagnosed with Alzheimer's? It specifically used the word Alzheimer's. My mom has Lewy body dementia. It was more the mental aspect before the Parkinson's. And when I looked at her most recent neurology notes just now, it doesn't mention Alzheimer's at all. I know when you were talking, you said it can develop into Alzheimer's. So I'm
No,
thinking the way
what
I
I
need to
said
answer this
was,
question is no.
yeah, what I said was we expect Alzheimer's to join it. It doesn't develop into Alzheimer's.
Join
It's that
it.
your person
Okay.
actually has more than one dementia. And Lewy body is
Okay.
considered a sporadic dementia, so it's not something I'd be worried about. If my mother had it, I wouldn't be worried about it. And you have to remember that I'm a specialist and a subject matter expert, so it's not at all unusual that I know research a physician may not know. So did that help at all?
Right. So, well, I'm trying to figure out, and the person,
And
the
the
broker
insurance form,
is,
the insurance form is trying to track whether or not you have Alzheimer's because their information is telling them everybody has Alzheimer's and your family doesn't have Alzheimer's. Your mother has a different
right.
variation of a dementia.
Right. So she doesn't have it. So I would correctly answer the question as no, she
No,
doesn't, even though I'm
right.
wondering, are they wondering about dementia?
They don't, I'm willing to bet you the insurance company doesn't know the difference between dementia and Alzheimer's.
That's my guess as well.
Yeah. So I would say, no, she doesn't have Alzheimer's. She has Lewy bodies dementia. So then they'll realize she has a dementia, and it's something usually they haven't heard about. So even though to me, Lewy bodies very common, fourth most common dementia, to people in insurance, it's very rare to them because most of the time what an insurance person sees are these three diagnoses: dementia
Right.
with behaviors, dementia without behaviors, or everybody has Alzheimer's. And that's dementia is
Right.
not the name. So you just did enough due
Right.
diligence and have a really good doctor that you knew what was going on. So I wouldn't worry about the Alzheimer's.
Perfect. I'll put no. Thank you.
And then we have Christina raised her hand.
Christina was joking.
Okay, we're going to go to, I think we just did Elizabeth.
Yes, you
Sorry.
did.
Okay. Keith, you have a question about vascular dementia?
Yes, thank you so much, Dr. Tam. Thank you for sharing your expertise with all of us this evening. My mother was diagnosed with vascular dementia roughly about 13, 14 months ago. And I reflect on a couple of comments that you've made in your presentation tonight. The first comment was a terminal diagnosis, and the second one was talking about these microvascular strokes. Recently, we've noticed that mom is having trouble when she's feeding herself with a fork to get to her mouth. And I'm just wondering, is that a progression of vascular dementia? Is there something else
It's a
that
progression. It's a progression of any dementia. So you remember Maslow and Erickson scales of development? We went from infancy to adulthood. The Alzheimer retrogenesis scale, retro is back to, genesis is the beginning, so it's the Alzheimer back to beginning scale. The person goes from adulthood back to infancy. So as you raise children, first we feed them, then we give them finger foods, then we give them a spoon, then we give them a fork, then we give them a fork and knife. If my person is having trouble using a fork, it's time to go to a spoon. And it also may be time to ask Anthem to have the speech therapist come in and do a speech swallow study evaluation. And also to check, sometimes they're not able to use the utensil. I don't have a fork near me. The utensil's not big enough for a handful of arthritis to hold. So I can't hold it well enough to get the food to my mouth. So we do a couple of things. We put just a simple foam tube over the utensil, makes it bigger, easier for me to grab. We may actually use a weighted utensil to give a person, especially a person with a tremor, an ability to get food. But the next step down from a fork is a spoon. The next step down from a spoon is finger food. The step down from a finger food or to a spoon becomes a mechanical chop. Then we go to finger food. Then we go to pureed food. So she's simply, you're seeing the natural digression of ability as the disease progresses.
Thank you for your help this evening. Appreciate it.
Yes, sir. Yes, sir.
So there's a question, is it important to get brain scans regularly so I know how much his disease has progressed?
No, that's torturous to the person with dementia. I mean, I'm not about to lay down in an MRI for you and listen to it go dong, dong, dong for an hour. Instead, what you use is your observational tools, because the person behaves in a certain way when a certain amount of brain damage occurs, and they only behave in that way once that brain damage occurs. So I don't need to keep giving Chris another MRI. I need to every 2 months check on my staging tool to see how he has progressed from the previous 2 months. And Nicole, you can't read the staging tools every day. You'll go crazy. Does that make sense?
It does. Thank you.
The static left and I thought, oh my gosh, I've lost the connection. Okay, so we use staging tools because it's not pleasant when you have brain damage to be gotten up, dressed up, taken somewhere, and get poked and prodded. There's nothing they're going to learn from it. It's a terminal progressive disease in any of its forms. And that's how staging tools allow you to know what's coming next, how quickly it's moving, and they're going to give you better answers than the physician will, because it's built to help family or professional caregivers understand where their loved one is right now with brain damage and what's going to come next. Okay, I'm sorry, it's never good news.
Thank you. Okay, so next, I'm afraid I'm going to say this name wrong. It's Dianeval? You raised your hand.
I think it might be Diane Ebel.
Oh,
Could
that
other
would make
kinds
sense.
of toxins such as mercury or mold cause dementia? Maybe if a person is sensitive to the toxin?
It would follow under toxic dementia. So I would go to nih.gov, because that's the repository of research. NIH, it stands for National Institutes of Health. And in the search bar, type in what you're looking for, but it's going to fall under toxic dementia. So yes, they're very rare, but people develop either cancer, and I think that's why they don't get found a lot of times, is the toxicity was so high they actually die of a cancer first. But we do have a whole set of toxic dementias. Smoking actually falls under toxic dementia, as well as under vascular dementia. So for mercury, you would need to look to see what studies. I've not seen any studies that indicate mercury causes dementia, but it makes sense that it could be out there. They're just so careful to watch for it. But if anybody's done research, because that repository picks up everything in the world, if any other country's done research on it, you'll find it.
This is Diane. Thank you for that. I have a follow-up question. Can anybody look at the NIH studies? Or
Oh, yeah.
Okay.
Oh, yeah.
Okay.
Yeah, and
Yeah.
just read on each study, just read the abstract, the sort of summary paragraph, and if it's got what you need in it, yay, email it to yourself, and if it doesn't, go to the next article.
Mm-hmm. You know, as I looked at all what you were saying, my husband has symptoms of in each of those things, you know what I mean? And he's really puzzling the doctor, who I think is very knowledgeable about all of these.
Is the doctor a specialist in dementia?
Yes, he is, and
How is
neuromotor. Well, he'll say.
How do you know he's a dementia specialist? Is it a neurologist who specializes in dementia?
Yes.
Okay, it has to be a neurologist who specializes in dementia. If you're seeing features of each of the 9 dementias, that'd be a little unusual, because the FTD would have killed your person a long time ago. They wouldn't live to have all these other dementias. So that'd be a little unusual. But I would definitely look at your itty bitty book, circle what looks familiar to you, because when families see, because who knows him better? You. When
Right.
families see multiple behaviors, you're seeing multiple dementias. It's just that nobody else may be around to see it. Now, I may be able to help you. How old is your fella?
73, and he's had ADHD, or that's what we were calling it. So he's had memory issues for quite a while. Now it's moving into some of the other things, like his short-term memory is totally shot.
So that indicates that Alzheimer's is present.
Yeah, but he can do all his ADLs, and he can. It's sporadic too. Like,
I would say I'd call, yeah, he can't really do all his ADLs if he doesn't have memory there. You're somehow helping him. So you can go to my website, or you can go to the back of your itty bitty dementia book. Will be a scale called the Bristol scale, and it's for the Bristol Medical School of Bristol, England. And it's how you actually measure ADLs and IADLs in your loved one. And so when you look at that, you may be able to fill that out and give your doctor much better information about what's actually going on at home. Because in our country, we're using Katz's scale, which was made in 1952 for normal aging. So by the time your fella does anything weird on the ADL scale, he's got severe brain damage. But if we use tools actually made for dementia, then that may make a big difference to you. In his 70s, there are several things that he would be and fall into the parameters of. So do the Bristol scale, like Bristol, England. Okay.
Mhm.
Look at that scale. Look at your dementia behavioral assessment tool. Look at your 9 most common forms, and remember toxic in case he was in the military or in a job that had toxicity. And then take that aggregate information to your physician, and because you should be able to figure out what it is, especially with the testing that they're able to do.
Yeah, the doctor thought it was frontotemporal, and he did some genetic testing because his mother had, just listening to you and my research, his mother had, I think, Parkinson's with dementia. His sister, I think, she was diagnosed with paranoid schizophrenic. I think it was Lewy body, knowing what I know now. And his brother had Alzheimer's. So, like, all his family members. And my husband is doing much better than they did. But, genetically, I'm wondering, should he
Just a
be.
bad mixture there. So,
Yeah, but
it's when the sperm cell and the egg cell come together, each side's carrying 23 of your DNA, and those two come together. Well, in some people, they unzip and they make a beautiful, brilliant person. In others, you don't get a good combination of those two forms of each person bringing their own genetic mixture, and you end up with kids that have something that's not good. So it could be that's going on. It could have been something they were exposed to. I'm sure somebody'd like to study it, but that's very hard for y'all. I'm so sorry.
thank you. Thank you so much. And that dementia behavior scale, that's on your website too, I think, right?
Yes, ma'am. All the tools that we
Mhm.
use in gerontology for dementia are observational tools, because we can't ask somebody with brain damage, do you feel bad?
Right.
We've been taught all our life to say, no, I feel fine. What are you talking about? So we have to use observational tools. And those of you who have a loved one on an antidepressant, when you do the Cornell scale for depression and dementia and they score on it, it means the antidepressant's not working. It doesn't mean they're pretending or they're faking. It means the medicine they're on is not working, and they don't have enough brain to be able to tell the doctor that medicine's not helping. So we use all these tools for pain, for anxiety, for psychosis, for depression. Everything we use is on the website. It's in the back of the itty bitty book, I believe. Nicole and Chris have it at Anthem. It's all available on the public domains because it's all information that I, as a gerontologist, know to use. And I think it's really helpful as you, as a family member, know to use it too, because it'll let you make better information to your doctor, let you ask better questions, and let you understand better what's happening. And I'm sorry, that must have been terrible for your family.
Yeah, well, thank you very much.
Yes, ma'am.
All of your presentations have been fantastic, and I've been passing it along to our dementia care club. So thank you.
Oh, good.
Thank you.
Wonderful. Glad to help them. Thank you, ma'am.
Okay, so we have several other questions, so I want to make sure we have time to get them all answered. It seems dementia is becoming more common. Is it mainly inherited, environmental causes, or what could it be?
We're seeing the largest population of people ever age. That's the baby boomer population. And so that's the reason for the numbers. The other theory is that human evolution is very slow, Nicole. But in 4 generations, we have gone from my grandparents who were born in the 20s, in the 1920s, ate about 1.5 pounds of sugar a year. And I'm in my 60s, I move 80% less than my grandparents moved because of all the automation around us. My grandparents moved less than their parents moved because of automation. Today's teenager, we believe, eats about 154.5 pounds of processed sugar a year. Our diet has changed, our exercise has changed, and human evolution is very, very slow. So go to the Million Veteran Longitudinal Study, and you will find 8 things to do to change your trajectory of living. And the first one, Nicole, is America's most hated word, exercise. And it's exercise at least an hour a day, not an hour a week. It is moving the human body. And that's one of the biggest things. So it's thought to be this huge population of people. Number one, exposure to a war. Things we don't talk about, there have been over 600 nuclear devices exploded into our atmosphere. It actually caused a change in one of our genes. So you've got that going on for all of us. And you've got stress that never existed before in ways that never existed before. And humans just didn't evolve to hear all the bad news that's happening all the time, everywhere, all the time, all the time. And so it's diet and exercise, and it's taking care of yourself, and it's just a large population.
Great,
It's just
thank you.
terrible, y'all. It's terrible. It's just terrible. We're all going there. Everybody, terrible.
All right, now we're going to take it to cannabis.
Okay.
In your experience, have you found CBD or cannabis to help with behaviors like anxiety or erratic behaviors?
The fear of using THC in any form with people with dementia is we're giving a drug that we typically label as a psychotic to people. So people with brain damage don't need a psychotic, so it doesn't have the effect that it was hoped for. And in Colorado, Nicole, they actually call them the dementia refugees because we see people leaving other states and moving to states that do have recreational or medical marijuana. The edibles only work on a person if there's a certain enzyme in your liver, so edibles don't work on everybody. Plus, the dosage is different. I mean, this is seriously powered stuff, but the friends of mine who are on the medical side of it would absolutely tell you do not do that. That is a psychotic drug you're giving to somebody who has brain damage, and it's not a good idea.
Great, thank you. What is the youngest someone can start exhibiting Lewy body dementia?
There have been people diagnosed as early as in their 50s, I believe. But I don't know where you'd even find that research. You might try nih.gov, but I do know of a case I read of somebody in their 50s.
Okay, great. The next question, it's kind of a long question. It's going about chemicals during wartime and if it's played a role in development of dementia. So
yeah, we know that men exposed to Agent Orange in Vietnam, that's a causation of dementia. We know that during Desert Storm, our soldiers were sprayed with our own nerve gas, so that's recognized as a causation. So our military people are certainly around the chemicals to develop a toxic dementia. Absolutely.
do you know if the agricultural chemicals being used in the 1930s were known to do the same?
There's probably somebody who's looking at it. I mean, I worried about it myself as a little kid growing up on a ranch when they would have me spray chemicals. I think that's going to come back and get me later. So I think, again, you'd need to go to nih.gov and look for a specific chemical and its relation. I would look, Nicole, for both the relation to cancer, aging, or a dementia.
Okay. And then what if physician refuses to provide a formal diagnosis of type of dementia?
You're at the wrong physician. You've got to be at a medical school that does the testing, a dementia testing place, a neurologist who specializes in dementia. Nicole, you and I both know only a few neurologists specialize in dementia. So you've really got to find a specialist. Otherwise, you're not getting the right information. One of the odd things about this country, among the many odd things about Americans, is we're the country that tells the person with the brain disease, you have brain disease. In other countries, they tell the families of the person with brain disease they have brain disease, and they tell them which kind. We're just behind the times here. So if I have a doctor who won't give that information, that doctor's also not going to give my person the medicine they need, the care they need. They're not going to be the doctor who says, give me your keys, you can't drive anymore. I'm making a report to the DPS. So, every time I see a doctor's license, Nicole, my first thought is, where'd you graduate in the class? Because common sense tells me 50% of doctors were in the lower part of the class. I also believe the same thing is true of specialists. I also believe that we have a large number of medical professionals that finish school and never open another textbook. So I think it's just not a good physician. I'd find someone else. And when I want to find a good physician, I call them memory care because they know every physician in town who specializes in memory. And you call them and ask them. That makes sense, right, Nicole?
It does. Thank you. Okay, so there's a question. What would you look for to determine if someone should be in assisted living versus memory care?
If they meet late stage 4 and stage 5 of the staging tool, if they're in that criteria, they should be in memory care. And I think, Nicole, what families don't understand is there's so much stigma about it when it's a brain disease. And memory care gives the best care. And all the research shows memory care gives the best care. We have higher staffing. We don't ask people, what do you want? We don't ask questions. Do you remember me today? We don't do that stuff. But what we do know that happens in assisted living care is, Nicole, if my mother has more dementia than your mother may have had a Bible study every week, but she's still going to be mean and snippy to my mother because it's a human reaction. So what we see happen is if I have a person that should be in memory care and assisted living, they get picked on. They get abused to the point that they won't come out of their room. They stop eating. They won't take their medicine. They don't take care of themselves. They actually take a very significant decline, when if the family would let the professionals tell them it's time for memory care and understand we're not trying to trick you, it's time for memory care. We're using criteria to make that decision. We understand we're taking away a person's independence, but we're doing it because they're a danger to themselves or they're a danger to others. The way they're a danger to themselves, not taking medicine, not eating right, could get in a car and drive it. The way they're a danger to the others, could get in a car and drive it. So we got to take care of these folks. And it's not a conversation I need to have with you, Nicole. You have brain damage. I'm not going to ask you, do you want to go here? I, as the adult with the full brain in charge of you, am going to make the best decision possible for you. I'm going to look at my staging tool. I'm going to say, well, Nicole's at the end of stage 7. This is going to give her the best shot of fun the rest of her life if I get her into memory care now. If I wait and don't move her till later, she's not going to get the joy in memory care that she would have had those final years. And that's just the reality. So we use the staging tool to give you a real guideline of when to move someone. You can't go into memory care just because you have a dementia diagnosis. You can't be in memory care just because you're in stage 3. You must meet the criteria of late stage 4, stage 5.
And can you remind everybody what that staging tool is called?
It's the Dementia Behavioral Assessment Tool. It's based on Reisberg's tool from 1972. It's just been updated and had the behaviors added that a professional or a family caregiver would recognize. If I wrote you a tool the way I read a tool, you wouldn't understand it because it's written in medical jargon. It's written for research. We wrote a tool to give the average caregiver a chance to look at their person, look at the behaviors, and know that that means that person's lost this much brain tissue. They actually have the mental equivalency of this age of a person. And I would never let a 12-year-old drive. I would never let a 12-year-old live at home alone because they used to. This isn't about used to. This is about where are they right now. And the staging tools allow you as a family or as a professional every 2 to 3 months, look at your person, start where you were last time because it only gets worse, and you can figure out how quickly your person is progressing. Don't read the tool every day, Nicole. You and I both know it'll make you crazy, make you think you've got it too, make you see things that aren't actually happening to you. But every 2 to 3 months, you need to check your loved one.
Is there a medication that is helpful for vascular dementia?
That would be something you'd want to talk to the doctor about. There's just a number of things. There may be heart medicine, there may be pacemaker, defibrillator, blood pressure medicine, low blood pressure medicine, blood thinners. You'd need to talk to your cardiologist. Just remember that the cardiologist doesn't talk to the neurologist, who doesn't talk to the geriatrician. So make sure you get all your doctors on the same page. Okay?
Okay. And then I'm sorry, I missed part of a question earlier. It was going back to the toxins. It was I'm especially curious to know Dr. Tam's thoughts on the water contamination at Camp.
Lejeune,
Yes.
it has been shown to cause Parkinson's disease dementia. And then from that, Lewy body, and from that, the Alzheimer's jumps right in there. So yes, there is a connection with that water poisoning. That I think has been accepted and recognized according to the advertisements I've seen to join the law firm. But yes, it is. It causes a Parkinson's, and Parkinson's becomes a dementia.
That was the last question in the chat.
We wore them out, Nicole. Good job.
I just want to see, though, I want to make sure, because there's 2 hands up, and I think we answered them, but I just want to make sure in case we didn't. Cindy had her hand up, and Christina, okay, and then Christina's came off. So Cindy, if we did not answer, oh, Christina. Christina was in the chat, right? Christina, you're the one you don't have. Okay, so Christina's done.
Y'all are done. That's it. We're done today. We're done.
We're done.
Finished. We're done. We're over it. Not
Can
doing
you
it.
just tell where to get the tool to know the stages? I was writing it down and I didn't catch all of that.
If you'll go to tamcummings.com, on the very first page at the very bottom, it says tools, and you'll find tools on there to measure your stress level as the caregiver. You'll find tools on there to measure your depression or anxiety levels, but you'll also find all the tools we talked about that are used for your loved one. And then Nicole, I don't know if you have those on your website yet, and they're all on the public domain as well. If you just Google them, you'll find them. I just tried to get them all together. I know what they are.
Thank you.
Yes, ma'am. Is
Um,
that it, Nicole?
Well, I'm going back to the last question again. Her
Okay.
dad's diagnosis is mixed early onset vascular dementia. Have you
got a
heard
good doctor.
if that is linked to the water contamination?
No, the water, the results that have been coming out about the water contamination are that you would now be watching for a Parkinson's to join it. So I would certainly talk to the physician, because it sounds like you got a physician that knows what they're doing, because you've got every vascular sign in the world and they won't put vascular dementia. So it sounds like you got a really good person there. Go back and talk to them, and then look for Parkinsonian features, which are going to be movement disorders. So talk to the doctor about it. That's going to be, you got a good person there. Go talk to them.
Okay. She said his dad had Parkinson's.
They're not seen as an inheritable disease. So the Lewy body and Parkinson's group are not very well understood. There's just not that much research in them yet. But I would go back to the doctor with those histories and see what else you come up with, because there may be something else there. And it's not going to change what happens, but it helps you understand it better. And I'd rather understand what's happening. Have I depressed everyone enough, Nicole?
I think so, Tam.
Nicole can always tell. They've had enough. Okay, well, everybody take care. Thank y'all for joining. Thank you, Anthem, again for doing this. It helps so many families just to understand what's going on. And then people feel free to reach out to me. If you reach out to me, put your phone number in, because I'm just going to send you an email that says, what's your phone number? Okay, and feel free to contact me. You're not going to upset me. I do a very unique job, and I'm happy to help people. And thank you to Anthem for what you guys do, for your dedication, and just all the good people you have working to do care. Thank y'all.
Thank you, Dr. Tam.
Have a good night, everyone.
Thank you.
Thank you. Good night.
Good night, Chris.
Thank you. Good night.
Good night.